Pyloric stenosis, pathogenesis, fibrosis around duodenal ulcer or juxtapyloric ulcer leading to gastric outlet obstruction, usually occurs over years of ulcer dyspepsia, may occur silently. The patients are usually capable of eating breakfast, then have a small lunch, but unable to eat in the evening because of a sense of discomfort and fullness, which is due to full stomach. Barium meal will often miss a small pyloric carcinoma, so gastroscopy is essential for diagnosis. Some cases of pyloric stenosis occur due to muscle spasm and marked inflammatory reaction around active duodenal ulcer, so they respond well to medical treatment as for uncomplicated ulcers. Clinical picture: symptoms, vomiting and pain. Initial periodic pain is lost and replaced by epigastric discomfort, vomiting, copious amounts of foul dark fluid characteristically in the evening, recognized undigested food eaten in the previous day, projectile vomiting and doesn't contain bile. Signs: general and abdominal examination. General underweight, ill-nourished, and may be dehydrated. Long-standing cases: electrolyte disturbance as hyponatremia, hypokalemia, alkalosis, and hypocalcemia, leading to tetany. Abdominal examination may show the contour of enlarged stomach, visible peristalsis passing from left to right. Succession splash can be usually heard. Differential diagnosis: carcinoma of the pyloric antrum. Investigations: radiological, instrumental, and lab. Lab: CBC, hemoglobin and hematocrit value, serum electrolytes, and bicarbonate. Instrumental: endoscopy, which shows stenosed inactive pyloric ring and will not pass the tip of the endoscope. The main value is to detect the presence of a tumor at the pyloric end of the stomach and to obtain biopsies from it and around. Radiological: barium meal will show dilated stomach, reaching pelvis, soup dish appearance, fluid level plus rouget, delayed gastric emptying. And then we have treatment. It requires surgery, but not an emergency. Preoperative preparation, aim to improve nutritive state to reduce morbidity and mortality, includes high protein fluid diet given IV, correction of fluid, electrolytes, sodium, potassium, chloride, and calcium, and acid-base balance, alkalosis, by proper IV solutions, correct anemia by transfusion of packed cells, chest physiotherapy, and antibiotics, often have pneumonitis due to inhalation, high risk of post-operative chest infection due to debilitated state, gastric lavage through nasogastric tube, operation, the standard treatment, truncal vagotomy and gastrojejunostomy. In the elderly or unfit patients, we do whether gastrojejunostomy alone or non-operative approach, endoscopic balloon dilatation, hourglass stomach, etiology, cicatrized saddle-shaped ulcer on lesser curvature, symptoms, gastric obstruction, but there will be early satiety and loss of weight, usually occurs in the elderly, should be differentiated from carcinoma of the stomach by endoscopy and a barium meal. Treatment: partial gastrectomy, removal of the distal pouch. Complications of gastric operations: we have early complications and late complications. Early complications: bleeding, source from the anastomotic line, diagnosed by fresh blood being aspirated through Ryle's tube. Treatment: conservative, if failed, reoperation. Stomal obstruction, causes: edema at the stoma, or sometimes after vagotomy, stoma is patent, but the stomach is atonic and doesn't empty, and this is treated by aspiration and IV therapy. But if the cause was technical error or obstruction of the gastroduodenal anastomosis by hypertrophied antral mucosa membrane, it's treated by surgery to correct them. Duodenal blowout: it follows Bell-Ross 2 anastomosis. Timing: around the 4th day. It may occur later. Causes: sutures taken in an inflamed or densely scarred duodenum, technical error such as obstruction of the afferent loop, excessive turning of the duodenum, too aggressive dissection leading to ischemia. If no drainage was provided, acute severe upper abdominal and lower chest pain with anxiety and tachycardia leading to generalized peritonitis. If drainage was provided with IV fluids without distal obstruction, all cases are cured. With distal obstruction, reoperation to relieve afferent loop obstruction. Post-operative pancreatitis: this is the last early complication. Late complications: recurrent ulceration, causes: inadequate gastrectomy, leaving part of the gastric antrum with the duodenum, leading to persistent hypergastrinemia, missing a trunk during vagotomy, recurrence of the original ulcer, site may be stomal on the anastomotic line or one side of it, whether gastric or jejunal. Clinical diagnosis: recurrence of typical ulcer symptoms. Pain may be referred to bizarre areas as hypochondrium or loin. Diagnosis: endoscopy is essential. Treatment, medical, surgical. Medical, proton pump inhibitors, controls almost all patients. Recurrence is common after drug cessation. Reoperation is usually needed. Surgical, depends on previous operation done. Following vagotomy, if there's missed trunk, divide it. No missing trunk, do antrectomy. Following gastrectomy, do vagotomy. Dumping, it has two components, vasomotor and GI symptoms following meals. Early dumping and late dumping. Early dumping, timing, within the first half hour after meal. Causes, rapid gastric emptying leading to delivery of hyperosmolar solution to the proximal small gut, shift of fluid from the circulatory plasma to the lumen of the bowel, leading to vasomotor effects. Clinical picture for the GI, epigastric fullness and pain with nausea ending in explosive diarrhea. Vasomotor, sense of weakness, flushing, and palpitation. Prevention, take small frequent meals rich in proteins and fats and less in carbohydrates with liquids only between meals. Treatment, assume Trendelenburg position. Operation rarely needed. For late dumping, timing about 2 to 3 hours after meals. Cause, rapid delivery of large amounts of carbohydrates to the bowel, leading to overshooting of insulin secretion and hypoglycemia. Symptoms of hypoglycemia, sweating, palpitation, tremors, and confusion. Prevention, frequent small meals of low carbohydrate diet. Treatment, carbohydrate ingestion. Biliary gastritis or alkaline reflux gastritis. Definition, reflux of bile through stoma in the stomach leading to diffuse gastritis. Investigations, endoscopy is mandatory. Treatment, only by surgery. Fashioning of a own Y anastomosis. Post-vagotomy diarrhea, tendency to lose stools, follows truncal vagotomy in most cases. Incidence, not common in Egypt. Etiology, obscure, but maybe due to dysfunction of the ileocecal valve. Bile acids being delivered too rapid to the colon. Treatment, gets better by time. Post-gastrectomy nutritional disturbances, weight loss, steatorrhea, anemia, iron deficiency or megaloplastic, vitamin B deficiency, calcium deficiency, early satiety, increased risk of pulmonary TB, increased risk of stomach cancer following gastrectomy. And this concludes the late complications. Biliary gastritis mimics recurrent ulceration, but with the symptom of bilious vomiting. Rarely, in about 3% of cases, the diarrhea is watery and explosive. Neoplasms of stomach, benign, malignant. Benign, leiomyoma, the commonest. Adenomatous polyp, neurofibroma, malignant. Adenocarcinoma, the commonest. Non-Hodgkin lymphoma, better prognosis than carcinoma. And GI stromal tumor, GIST. Leiomyoma, the commonest benign tumor. Symptoms, vague. Investigations, barium meal, showing smooth filling defect. Complications, it can bleed or may perforate the stomach. It occasionally gives rise to epigastric mass. Malignant transformation can occur, nowadays considered as a type of just GIST, gastrointestinal stromal tumor. Carcinoma of the stomach. Incidence, it has been falling steadily throughout the world except in Japan, is of almost epidemic proportions, 100 to 100,000 of the population. In general, any factor causing gastritis can cause carcinoma. Presence of nitrates in food lead to production of N-nitrosamines by the action of bacteria in the chlorhydric stomach. Whatever the actual factor, carcinoma will occur if there is gastritis and genetic predisposition. Etiology of carcinoma of the stomach, chronic irritation, chronic lesions, and genetic predisposition. Chronic irritation by dietary, such as spices, increased salt intake, tobacco, alcohol, and nitrosamine compounds, following partial or subtotal gastrectomy. Biliary reflux gastritis leading to remaining gastric stump carcinoma. Chronic lesions, chronic H. pylori infection, increasing the risk about 3 times. Factors causing a chlorhydra, such as viral infections. Benign gastric neoplasms, such as gastric polyps, and benign gastric ulcers, which is very rare. Genetic predisposition, such as family history, persons with blood group A, and pernicious anemia. Pathology, site, 50% near the cardia, 35% occurring in the pyloric antrum, 10% diffuse infiltration of the whole stomach, linitis plastica. Macroscopic types, 2 types, early gastric cancer and advanced gastric ulcer. Early gastric ulcer, only the mucosa and submucosa are infiltrated, only diagnosed if screening programs done by endoscopy, and may be protruding, superficial, or excavating, penetrating. Advanced gastric cancer, the usually diagnosed type in practice, forms fungating cauliflower-like mass, ulcer with raised indurated edges, colloid carcinoma. All layers of stomach are infiltrated by areolar tissue containing transparent gelatinous substance. The diffusely infiltrating variety, Rhinitis plastica, the wall of the stomach is greatly thickened and indurated while the lumen is greatly reduced, may occur only in the antrum or the stomach diffusely. Mucous membrane is intact and may be missed by endoscopy. Microscopically, adenocarcinoma, commonest type, various grades of differentiation. The less differentiation, the worse the prognosis. And colloid carcinoma, bad prognosis. Rhinitis plastica, difficult to find malignant cells under microscope, bad prognosis. Spread, direct lymphatic blood and transcoelomic, direct infiltration of the wall of the stomach in depth, circumference, and length. After that, it will infiltrate neighboring structure as the liver, spleen, pancreas, or colon. Lymphatic, both permeation or embolization. 2 perigastric lymph nodes first, then 2 more centrally placed groups. Blood, mainly to the liver, very rarely beyond it to the bones. Transcoelomic, Krickenberg's tumor, ovarian secondaries in younger females when the ovaries are not yet atrophic. Blummer's shelf, metastasis to the Douglas pouch. Clinical picture, dysphagia, gastric outlet obstruction, symptoms of advanced disease, and uncommon presentations. Dysphagia with cancer near the cardia. Sometimes we have loss of appetite. Gastric outlet obstruction with a tumor near the pylorus. Symptom of advanced disease, anorexia, rapid weight loss, vomiting, and vague discomfort after meals. Uncommon presentations, epigastric mass, hematemesis, and melena. Investigations for diagnosis and for staging. And finally, for follow-up tumor markers, CEA, for staging, abdominal sonogram, CT scan, endoscopic ultrasound, and PET CT scan. Abdominal sonogram for detection of liver secondaries, assess lymph node involvement, less important. CT scan to detect lymph node involvement, more accurate, helpful in pre-operative staging of the disease. Endoscopic ultrasound detects the depth of invasion of the gastric wall, and PET CT scan to detect metastasis. For diagnosis, CBC, micro or macrocytic anemia, endoscopy, directly view the tumor from which multiple biopsies should be taken. Barium meal, overall accuracy is 75%, should always include views taken in the Trendelenburg position. To detect growth situated in the fundus and cardia, it shows cauliflower-like mass, persistent irregular filling defect. In malignant ulcer niche outside the ulcer-bearing area, and in Rhinitis plastica, marked narrowing of the lumen of the stomach, but the flow of barium is not interrupted. And finally, we have diagnostic laparoscopy. Treatment for early cases and in patients with incurable or irresectable lesions. For early cases, the aim is to cure the patient, achieved by radical operation, which includes removal of tumor with adequate safety margin of at least 5 cm above it and 1.5 cm of the duodenum below it. Both ommenta, greater and lesser ommenta, are removed, and all the draining lymph nodes with ligation and division of the vessels located around as left gastric, right gastric, and 2 epiploics. The extent of resection depends on the site of the neoplasm. Lower 1/3, the operation would be lower radical partial gastrectomy, anastomosis, the remaining upper stomach to the jejunum, and this is called Barros 2 or polyagastrectomy. Middle third, total radical gastrectomy, esophagus to a row in Y loop of jejunum. Upper third, esophagogastrectomy through thoracoabdominal incision to guarantee upper safety margin. Esophagus is anastomosed to a row in Y loop of the jejunum. Patients with incurable or irresectable lesions may benefit from various palliative procedures, as for resectable tumors, palliative gastrectomy, the best palliation. For irresectable tumors in the pyloric region, anterior gastrojejunostomy. In the upper stomach, esophagojejunostomy. For inoperable, non-resectable tumors, incompletely resected or recurrent cases, radiotherapy and chemotherapy. Unfortunately, they offer too little for these miserable patients. Prognosis. It depends on many factors. The most important are histological type differentiation, depth of penetration, presence or absence of lymph node involvement. Only about 40% of patients are found to be operable at exploration. The overall 5-year survival is 10 to 20%. Despite the great advances which have occurred in surgery, radiotherapy, and chemotherapy, the prognosis of gastric cancer has remained bad, except in Japan, due to screening programs which provide early detection. Gastrointestinal stroma tumors, or GIST, G-I-S-T, formerly were called leiomyoma, site common in the stomach and small intestine. Source: they arise from Cajal cells. They lie within the stomach wall. Symptoms: may present with abdominal mass, hematemesis, dyspepsia, may reach large size, and may have pseudocapsule. Treatment: local gastric resection. Recurrence is common. And there's something called Gleevec, a tumor-specific monoclonal antibody against some tyrosine kinases of the tumor, has shown excellent clinical results. Gastrostomy. Definition: opening of the stomach on the skin. It may be temporary or permanent. Indications: to decompress the bowel as an alternative to post-operative nasogastric intubation, or to feed patients who cannot ingest food orally for weeks or months, as in operations on the mouth and pharynx. To decompress the bowel. Advantages: more comfortable, doesn't interfere with deep respiration and coughing, which are encouraged to avoid pulmonary complications, and of advantage in the elderly with chronic pulmonary diseases. Technique: we have STAMS gastrostomy and percutaneous endoscopic assisted gastrostomy, PEG, PEG. STAMS gastrostomy, the traditional method. Small puncture is made in the middle of the anterior surface of the stomach. Large malcut or mushroom head or Dipazar tube is inserted 1 to 2 inches into the lumen. 2 concentric silk sutures are used to invert the stomach wall, a snug seal and serosal lining to the tubal tract. The tube is brought out through a tightly fitting stab wound in the left upper quadrant. The stomach is firmly attached to the abdominal wall by sutures around the exit side of the tube to prevent early retraction and leakage into the peritoneum. When it's no more needed, the tube is simply pulled out. Tract closes spontaneously because it's lined by serosa. Percutaneous endoscopic assisted gastrostomy, or PEG, increasing popularity. Gastroscope inserted into the stomach, used to inflate it. The gastroscope light is made to shine through the anterior stomach wall and anterior abdominal wall. Under local anesthesia, a tracker and a cannula puncture the anterior abdominal wall and enters the stomach. A self-retaining tube is introduced through cannula into the stomach and its balloon is inflated. Bariatric surgery. Obesity is a pandemic health problem worldwide. Obesity shortens life expectancy with increasing body mass index. Morbid obesity is projected to overtake smoking as a leading cause of deaths in the near future. Non-operative management with diet, exercise, behavior modification, and medications rarely achieve adequate weight loss. Medical treatment, once stopped, weight is regained. Etiology of bariatric surgery involved genetic, environmental, metabolic, and psychological factors. Grades of obesity measured by calculating body mass index, weight in kilograms over height in meters square. And we have classification. So obese, starting from body mass index 30 to 34.9, severe obesity grade 2 from 35 to 39.9, morbid obesity grade 3 from 40 to 49.9, and super morbid obesity grade 4 if body mass index exceeds 50. Complications: comorbid diseases, which affect nearly every organ system, as type 2 diabetes, cardiovascular diseases, hyperlipidemia, hypertension, hypoventilation syndrome, asthma, and sleep apnea. Stroke, arthritis, urinary incontinence, depression, gallbladder diseases, several types of cancers. The most commonly performed procedures for obesity are laparoscopic Roux-en-Y gastric bypass, laparoscopic mini gastric bypass, laparoscopic sleeve gastrectomy, and finally laparoscopic adjustable gastric band. Management of obesity surgery remains the best option for many morbidly obese patients, since medical therapies haven't shown to be effective in maintaining long-term weight loss in a morbidly obese patient. Requirements for bariatric surgery: body mass index exceeding 35 kg per meter square, or body mass index equals to or exceeding 30 with comorbidities, provided that failed attempts at diet and exercise, motivated, well-informed, and free of significant psychological diseases. Pre-operative assessment and investigations: routine investigations, CBC, blood sugar, urea electrolytes, KIFT and LIFT and TIFT, hormonal profarity, SHT4 and plasma cortisol, psychological assessment. Bariatric surgery procedures: bariatric surgical procedures cause weight loss by causing malabsorption of nutrients, combination of both gastric restriction and malabsorption, restricting the amount of food the stomach can hold. Laparoscopic Roux-en-Y gastric bypass, the gold standard surgery and the most commonly performed. Advantages: provides significant long-term weight loss, 60 to 80%, restricts the amount of food that can be consumed, lead to conditions which increase energy expenditure, typical maintenance of more than 50% excess weight loss, less absorption of calories, nutrients as it bypasses a large segment of the small bowel, rerouting of the food stream, changing in hormones such as ghrelin and leptin, promoting satiety and suppressing hunger. Disadvantages: technically more complex operation than the AGB and LSG. AGB is the adjustable gastric band and LSG is a laparoscopic sleeve gastrectomy. Because it could result in great complication rates, it can lead to long-term vitamin, mineral deficiencies, particularly deficits in vitamin B12, iron, calcium, and folate, requires adherence to dietary recommendations, lifelong vitamin, mineral supplementation, and follow-up compliance. Laparoscopic mini-gastric bypass, small gastric pouch, 50 milliliters, fashioned along the lesser curvature of the stomach and anastomosed to a loop of the small bowel 2 meters from the duodenojejunal flexure. Laparoscopic sleeve gastrectomy, approximately 80% of the stomach removed, and the remaining stomach is a tubular pouch. Advantages include restricting the amount of food of the stomach that can hold, inducing rapid and significant weight loss that comparative studies find similar to that of the Roux-en-Y gastric bypass, requires no foreign objects and no bypass or rerouting the food stream, involving relatively short hospital stay, causing favorable changes in gut hormones which suppress hunger, reducing appetite and improving satiety. Disadvantages: non-reversible procedure and has the potential for long-term vitamin deficiencies. Laparoscopic adjustable gastric band, inflatable band, is placed around the upper portion of the stomach, leading to small gastric pouch above the band and the rest of the stomach below the band. The size of the stomach opening can be adjusted by filling the band with sterile saline, which is injected through a port placed under the skin. Advantages: reduces the amount of food the stomach can hold, induces excess weight loss of approximately 40 to 50%, involves no division of the stomach or rerouting of the intestine, requires shorter hospital stay, less than 24 hours, reversible, adjustable, lowest rate of early post-operative complications and mortality, and has the lowest risk for vitamin or mineral deficiencies. Disadvantages: slower, less early weight loss than other surgical procedures, greater percentage of patients fail to lose at least 50% of excess body weight compared to other surgeries commonly performed, requires foreign device to remain in the body, possible band slippage or band erosion, mechanical problems with the band, tube, or port, small percentage, can result in dilatation of the esophagus if the patient overeats, requires strict adherence to post-operative diet and to post-operative follow-up visits, and finally, highest rate of reoperation. And this concludes our part for the stomach.